it to Ravi.
Okay, hi there. Can people hear me? Just checking. Yep, okay. So, hi. Welcome to this session on paediatric nephrology. So essentially it's going to be a series of SBAs, and hopefully there will be something in here which is of benefit. So I'll be covering some more basic aspects of paediatric nephrology, and as the session progresses, we will cover slightly more challenging areas as well. All of this will be mapped to pretty much a UK MBBS curriculum. However, a lot of it is not necessarily strictly based on UK guidelines, so it should be applicable to those and other courses as well. And hopefully, as mentioned, you might find something of use, whether you're just starting off in pediatrics or whether you do just sit your MBBS finals and are looking for something a bit more challenging. Okay. And as mentioned earlier, I'll be covering questions towards the end, but feel free to post your questions as we go along, and I'll take a look at them at the end. Okay. So we'll start with the first question. And we'll give roughly a minute for people to answer.
Uh, 10 seconds left.
Okay, so we've got a range of responses. So just over half the group have gone for option C, which is EGFR. And another third or so have gone for option B, serum creatinine. And then there's a few people who've gone for A and D as well. And nobody's picked E. Okay, so I thought I'd do this question because it relates to quite a functional aspect of pediatrics and how you look at renal function. And it doesn't matter whether this child has had a renal transplant or not, okay? But the correct answer to this question is option B, okay? And the reason this is the case is because essentially the EGFR is a function that's derived from, well, the main way we derive the EGFR is using the MDRD equation, the modified diet and renal disease equation. And that formula comes about through essentially a study in adults. So EGFR is not valid for use in children. So the main way we actually check and track renal function is serum creatinine. And this applies throughout pediatrics up until the age of 18. Now, we don't really tend to look at urea because that tends to fluctuate acutely and varies more with states of dehydration. Albumin, once again, is not a marker of renal function. However, you might see a low albumin if somebody does have a glomerulonephropathy, such as minimal change disease, where albumin can leak out, so it drops. And tacrolimus trough dosing won't help either. So we do monitor that in renal transplant patients. However, we do not use that to track renal function. Okay. So essentially, while the EGFR, certain lab computers may just automatically generate an EGFR number. However, it's worth noting that it's not valid. It's not validated in the pediatric population. And a lot of computer systems will automatically just omit the EGFR if you do use these in children. Yeah, so we typically look at creatinine. Okay. But that's just a key one to highlight because you guys will all be qualifying and monitoring bloods in children. This is a good way to understand how we do it. Okay. So question 2, so building up now. So we have a 2-month-old in the emergency department and she's had 2 temperatures above 39. And a septic screen has taken place and we've done urinalysis and cultures. So The question is, what would be the most appropriate method for obtaining urine specimen in these investigations? So I'll do it for a minute.
Ten more seconds.
Okay, so let's see the results. So there, 50% exactly have gone for option D, and the two next most popular options are option C, urine collection pads, with just around 20%, and option A, where 15% of you have gone for a collection bag. Now, I appreciate, depending on where you're tuning in from around the world, it may depend on what this answer might be, okay? But for the purposes of this question, the correct answer is option C, okay? So these are all methods by which we can collect urine samples in children, okay? Essentially, E is inappropriate for the most part because it is very invasive, and we don't typically tend to do that in pediatrics unless we absolutely have to. And in-out catheterization, once again, we don't tend to catheterize children too often, and we rarely do in-out catheterization just to obtain a urine sample. Now that leaves options A, C, and D, right? Now, in certain parts of the world, collection bags are common. And what collection bags are, for those that haven't seen them, is essentially a plastic bag with an opening on them, which you place over the genital area so that female patients can pass urine into, or you pass the penis through it so that it can then collect the urine when the baby passes urine. However, there is increasing evidence that these get contaminated and aren't very cost effective. And for the most part, across the UK, we don't tend to see collection bags too often. Okay? So that leaves options C and D in most cases. Now, a clean catch sample would be ideal. However, the key thing to bear in mind is that you've got a 2-month-old patient, and trying to, essentially, the best way to get a clean catch sample is obviously to encourage the patient to pass urine, and you want somebody who can follow instructions. Now, this is not really possible in a 2-month-old. So by far the most common practice utilized is using urine collection pads. And this is essentially a specially made pad that you can line the nappy with. And when the baby passes urine, the pad soaks it up, and you can then use the urine from that pad for urine analysis and also sending it off for cultures. Okay, it is really important to use collection pads, and you cannot just use the nappy itself, as that tends to contaminate the sample and affect the results. Okay. Yeah. So essentially, these are the main ways you can get a sample. Now, there is some evidence suggesting you can stimulate a child to potentially pass urine, even if they're non-potty trained, and that's something called the quick wee method. Okay, and that is so what you have to do for that is you have to clean the area, and then you need to be ready with your collection pot, and you can pass essentially a damp piece of like cotton wool effectively in circles in the suprapubic area. What you've then got to be ready for is for the child to pass urine, and then you've got to catch it. However, while using this method is shown to be a bit better than using a placebo method or not doing anything at all, it's not quite common practice just yet, and there's a bit of debate about it at the moment. Okay, so clean catch would ideally be appropriate. However, it's quite fiddly and not always guaranteed. I've got a picture of a collection bag here for those that are interested in seeing it. But depending on where you are, these will either be really commonplace or not commonplace at all. Okay. Question 3. So previously well 8-year-old girl is seen at the GP following 5 days of dysuria, and her urine dipstick is listed below. She started on antibiotics, and the question is, what additional investigation should this patient have?
Ten more seconds.
Okay, so just over half the group has gone for option E, and then another, about a third of you have gone for option A, which is ultrasound. So this question is rooted in the NICE guidelines for children with urinary tract infection. Okay? And the correct answer for this one is option E. Okay, so for any child, regardless of their age and how they're presenting, if you suspect they've got a UTI, you need to send the urine sample off for microbiological analysis. Okay, you want to do culture and sensitivities on it so that you can guide your therapy. And this is especially important in females who are more prone to getting UTIs. And essentially, it is important to keep sending these off for culture so that you can characterize what bugs are growing and if there's any resistance patterns forming. Yeah. And that is both, even if you have a conclusive urine dip picture where you have leukocytes and nitrites positive, and especially if you have an ambiguous picture where if only leukocytes or nitrites are positive in isolation. Okay, and I put ketones as trace here because that is also quite a common finding. And generally, when children are a bit unwell, they don't tend to eat as much. So as a result, they sometimes go into a mild ketosis. So you might find some ketones in the urine. Okay. But as the GP did here, they started them off on empirical antibiotics. But what you should ideally do is with the urine sample you did the urine dip on, you should send it off for culture. Okay. Urine beta-HCG would test for pregnancy. And while you would typically do that in a female of reproductive age, especially because you want to avoid giving some antibiotics such as nitrofurantoin or trimethoprim, which are usually first line, and because they're teratogenic, an 8-year-old isn't quite at reproductive age. So perhaps we jumping the gun a bit to do a beta-HCG. Okay. And then the other 3 are investigations you can do depending on whether they have an atypical picture or not. And some of this happens later down the line once you get to urine culture results. Okay. And we'll talk about this on the next slide. But essentially, the key thing to know for you guys is to look at the NICE guidelines for UTIs in children. Okay. It is a bit more complex than what we do with adults. And the reason we are so careful about this is because of the risk of renal scarring, okay, and potentially tipping them into renal failure. Yeah, both acute and chronic renal failure. And also recurrent UTIs in children might be a result of other underlying pathology. One key thing you might want to look up is posterior urethral valves, especially in boys, which predisposes them to things like vesico-ureteric reflux. Okay. Now, the imaging we can do, there are 3 options, and depending on the patient's age and how they present will depend on what we do. The NICE guidelines outline what we do. However, I think you typically would not be expected to memorize the schedules because that is a bit brutal. And as guidelines have progressed, they've gotten more and more complex. However, what you would be expected to do as an undergraduate is at least appreciate that we need to do these scans and imaging investigations and why we need to do them, okay? So I'll start off with hopefully the most obvious one, which is an ultrasound scan. So we typically do an ultrasound scan to check for any structural abnormalities of the kidney and urinary tract. Okay, this might identify things like a horseshoe kidney, yeah, or any other like significant malformations. We do a DMSA scan, okay, and what that does is it's a dynamic scan which essentially looks at renal function. Okay, it's a check for renal scarring in particular. So we do not do a DMSA scan acutely. We often do it a few months after their acute presentation. Okay, because the scarring is a chronic process and you won't necessarily see any scarring straight away. Yeah, and an MCUG is a micturating cystourethrogram. And that is a study where we basically put some radiopaque dye, we insert it into the bladder, and then we get the child to pass urine. And what that does is it looks at the flow of the urine and it sees whether they've got things like vesico-ureteric reflux or things like a dysfunctional bladder, which once again can predispose you to having UTIs. Okay, so the more important thing for you guys to know is that these investigations exist and why we do them. And for some of you, it would be worth looking up how to counsel parents about this. And a good way to start is to maybe look at a few patient information leaflets to see how you might describe this to a parent, because it's quite routinely the job of a foundation doctor to discharge the patients and signpost them saying they'll be getting letters in the post soon about some subsequent investigations. Okay. And I've just put this here for reference, but once again, the NICE guidelines do clearly outline what constitutes an atypical UTI. And these tend to often require you to do these investigations. Okay, but there's evidence of any poor urine flow, raised creatinine, if they're septicemic, or if your culture grows non-E. coli organisms. Okay, but all of this is worth reading thoroughly in the NICE guidelines. Big topic. So I've got question 4 here. I won't read out the whole stem, but I'll give you guys a minute and a half. Shall we say, yeah, let's do a minute and a half to read this question and pick an answer.
Another 30 seconds, guys.
Okay, interesting question. So there's pretty much an even spread between options A, C, D, and E, okay, with a roughly 20% going for each one, but there are slightly more for option A, and then around 10% of you have gone for option B. Okay, so the diagnosis that's being alluded to here is Haemolytic Uraemic Syndrome. Okay. And this is essentially a complication, usually of a bacterial GI infection, okay? And it often starts off quite slowly, so you don't tend to get Haemolytic Uraemic Syndrome straight away once you get the onset of diarrhea. It tends to essentially accumulate after the first couple of days. It tends to go on for a week, and then patients start becoming particularly unwell, okay? So there's lots of exciting things going on with the bloods here. You can see that they've got some sort of anemia. they have some degree of thrombocytopenia. Yeah, their creatinine is raised, their urea is raised, and they've got quite a good CRP there of 40. Okay, so this picture is in keeping with hemolytic uremic syndrome, especially the fact that the platelets have gone low, and so has the hemoglobin. Okay. And what's going on is that essentially the bacteria, classically Shigella or E. coli, tend to produce a toxin, yeah, that basically tends to cause TTP, yeah, and hemolysis. And sorry, TTP is thrombotic thrombocytopenic purpura. Okay. And so in keeping with this, with hemolysis, one would tend to see raised bilirubin. So that's the correct answer here. You wouldn't see low lactate dehydrogenase, but if there is acute hemolysis going on, you would tend to see raised lactate dehydrogenase. You don't tend to typically see too much abnormal liver function. So you wouldn't tend to see a raised ALT, and nor would you tend to see low albumin. So you don't tend to get significant acute liver failure, nor do you tend to get albumin lost via various enteropathies or leaking through the kidney. Okay, and you don't tend to see a raised creatine kinase. That is essentially, for most parts, a result of muscle breakdown, which is not happening here. Okay, so this is assessing your knowledge of disease processes rather than the overall diagnosis. And the correct answer is A, raised bilirubin. Okay. And it is worth knowing about hemolytic uremic syndrome because children in particular are especially prone. Yeah, so you will tend to see children get hemolytic uremic syndrome, especially. And the key risk factors especially include having poorly cooked meat and basically contact with animals. Okay, so if you went to a petting zoo, that would be the key risk factor here. Okay, so what we call here is typical hemolytic uremic syndrome. And what patients tend to have is they often develop bloody diarrhea as a result of the toxin from the bacteria. And then because it is a GI infection, they would also get vomiting and abdo pain as well. And the abdo pain is particularly bad. Most of these bloods were covered here, but they'd also have raised bilirubin, as the question was asking, and they might have a raised potassium due to an AKI or just due to acute hemolysis. You would see haptoglobin go low, and you'd also see a raised LDH. Now, the key thing to cement here is the management is essentially supportive. You give lots of fluids and you monitor their fluids very carefully, and you need to basically correct any electrolyte disturbances. If they become profoundly anemic, you want to give them blood transfusions, okay? And in severe disease, they might end up getting dialysis. Now, even though this is typically caused by an underlying bacterial infection, we do not tend to give antibiotics routinely. And there have been quite a few studies in children and adults that have shown that actually antibiotics either make no prognostic difference, either in terms of mortality or disease length. So it makes no prognostic difference in that sense. But in some cases, it can actually make things worse. And the main hypothesis underpinning that is if we give antibiotics to a high bacterial load, it causes lysis of the bacteria and they just release all their endotoxins at once, which actually just exacerbates hemolytic uremic syndrome. Okay. And as part of your fluid monitoring, you'll want to do daily weights, daily urine analysis, and you want to do bloods daily. So these children become quite unwell, but essentially management is supportive. Okay. And key risk factors you want to ask for. So if somebody comes in with bloody diarrhea, you want to ask for animal contacts, if they've had any barbecues especially, or if they've been in contact with somebody who they themselves were unwell recently. Okay. The management for HUS is heavily fluid-based and typically with transfusions. Okay. And the key thing to remember is we don't tend to give antibiotics. Question 5. So you have a 4-year-old girl in the emergency department and she's got profound proteinuria. She's got marked edema, which is also present on her face, and her bloods are shown below. So we'll give about 1.5 minutes for this question. And the question is, what drug should you prescribe?
30 seconds left.
Okay. Yeah, so 80% of you went for option A, which is prednisolone, and another 10% of you went for option C, which is albumin. Okay. So the correct answer is indeed prednisolone, and I imagine most of you did get the underlying diagnosis, or rather the implication, which is this child has nephrotic syndrome, and we typically tend to assume children with nephrotic syndrome in their first run have minimal change disease. You might see some pediatricians now veer away from instantly saying they've got minimal change disease because we don't have a biopsy confirmation. And what we now tend to do is recognize the uncertainty by saying they've got idiopathic nephrotic syndrome. Yeah, but essentially from prior data, we know that the vast majority of children who have an isolated significant proteinuria, tend to have minimal change disease. And because of that, we tend to empirically start them on prednisolone, to minimize their complications. Now, the bloods here essentially are those typically in keeping with nephrotic syndrome. And the main abnormality seen here is a very low albumin, which is in keeping with essentially the podocyte effacement that happens, and large proteins tend to leak through. And that is why they get marked edema, and significant proteinuria. The one key risk that these children can have is that they might become dehydrated. So you might tend to see their urea and their sodium climb, depending on what their fluid status is like. Okay. In adults with nephrotic syndrome, essentially the pathologies vary a bit, and it's not typically minimal change disease, and they have other causes which can make them more prothrombotic. And they typically are given low molecular weight heparin as well to minimize their chances of developing clots. We do not tend to do this in children that often, We don't tend to do it routinely. Albumin we do not tend to give, unless advised by a specialist. And essentially giving albumin might transiently help, and it might make this number prettier, but you are not correcting the underlying defect. So a lot of this albumin may just eventually leak out again. And patients with nephrotic syndrome, if they are profoundly nephrotic, they are more prone to getting infections. However, we do not tend to give trimethoprim. In some cases, we do give things like penicillin prophylaxis, especially if they've got ascites, to minimize their chance of developing peritonitis. And the other reason we're particularly worried about infections is because your immunoglobulins are proteins and they can leak through your urine as well, making you more at risk. But trimethoprim is not the antibiotic we give. And then cyclosporin does have a role to play in nephrotic syndrome. However, it is a second-line drug. So we tend to use prednisolone first. And the key thing to bear in mind is that 9 out of 10 children will respond to their course of prednisolone. However, if they don't, we typically then just tend to start other immunosuppressive agents, of which cyclosporin is one of them. And we might, at that point, potentially consider doing a renal biopsy as well. So prednisolone is the correct answer. And generally, the prognosis is good. And we've covered these points here. So if steroids fail, so this is the minority of children, we tend to give other immunosuppressive agents. And then essentially, at that point, we'd consider doing a biopsy. Prophylactic antibiotics do tend to be given. It sort of varies depending on what their presentation is like, but they can be given and they do have a role. However, in children, low molecular weight heparin is not given routinely in the UK. Question 6. So you see a 10-year-old boy and he's got blood in the urine. Okay? He's normally well, and you confirm that there's blood with the presence by using urine dipstick. So what is the most likely diagnosis?
Ten seconds.
Okay, we've got pretty much a 50-50 split between A and B, okay? And that is precisely the split I'd have expected, yeah? So, yeah, they've got some sort of glomerulonephritis, okay? They've got blood in the urine, okay? Now, just talk about the other options. So, FSGS, focal segmental glomerulosclerosis, is you typically see a degree of proteinuria with that and potentially some blood. Okay, but because there is purely the presence of blood on this urine dipstick, FSGS is unlikely. Okay, with a UTI, we'd expect to see leukocytes and nitrites on the urine dipstick. Yeah, and with myoglobinuria, that could cause a false positive. However, given the patient's history, there's nothing to indicate some form of muscle damage or him being like very unwell. Okay, so C, D, and E are unlikely. Now, both options A and B can present in relation to an upper respiratory tract infection and have hematuria. And one of the key ways to split the difference between the two is looking at the onset. Okay, so essentially, post-streptococcal glomerulonephritis tends to come a few weeks after the illness, whereas IgA nephropathy tends to occur alongside or within days of the illness. Yeah. So in keeping with that, the most likely diagnosis here is option B. Okay, but it's worth knowing the difference between the two. So here is essentially one way to split the two. Yeah, and the key thing to focus on is the onset. Okay. And then a lot of these other differences, you wouldn't necessarily go looking for C3 straight away, especially if you're in primary care. Probably sort of speak to the pediatric team, or you may actually need to contact specialists after that. But C3 is one way to distinguish between the two. And then hematuria tends to be a lot more present in IgA nephropathy. But once again, the fact that they've got hematuria makes this information somewhat irrelevant. And finally, one subtle difference that you might want to use for your diagnostic reasoning, but it's not watertight, is that IgA nephropathy tends to occur in adolescents, whereas post-streptococcal glomerulonephritis is a lot commoner in children, younger children especially. Okay, but the key thing you'd probably want to look at is the first row here. Okay, and this is often a key area people get tangled up in. So, question 7. So this is where it's getting a bit trickier. Okay, give you a minute to answer this question, and we'll talk it through in a few slides' time. So we'll do 2 questions back to back.
10 seconds.
Okay, so 2/3 of you have gone for option B, which is urine protein to creatinine ratio, and then 1/5 of you, so 20% of you have gone for option C, and then there's roughly an even spread between the other 3 options. Okay, so the correct answer to this question is option C. Now, option B would also be done as well, and you typically do that probably after option C. But what this question is getting at, well, I shall discuss in a short while, but is something called orthostatic proteinuria, okay? And it is the most common finding of persistent proteinuria, and it tends to occur in adolescents. Yeah? And what you tend to see is essentially proteinuria that gets worse across the day. Yeah? Otherwise, the patients are completely well and it tends to have a good prognosis. So what you typically do is you'd want to evaluate urine dip in the morning, and then on the same day after they've been mobile, you want to do it again to see whether it worsens. And subsequently, you would then typically do a protein to creatinine ratio to try and quantify the amount of protein precisely. However, urine dips would give you a good approximate marker. And later on, you would also do an abdominal ultrasound scan, yeah, just to see if there's anything structurally wrong with the kidney. There's no indication here of a UTI. He's only got proteinuria on his urine dip, and he's otherwise asymptomatic. So there's nothing pointing towards a UTI. And you wouldn't typically refer straight away. You would want to do at least option B and C first. And you probably want to arrange an ultrasound scan and then seek advice from pediatrics once you've got all the information. Okay. Question 8. So we'll give a minute and a half for this one, as this is once again a bit trickier.
Thirty seconds.
Okay, so half of you went for option A, just transient proteinuria, and then roughly an equal amount of you went for options B, C, and D, and a handful went for option E. Okay, now this is a tricky question, okay? You guys did very well. Yeah, so the correct answer is transient proteinuria, okay? And essentially what tends to happen is when children have a seizure, they do get a proteinuria, however, it tends to resolve within 24 to 48 hours. Yeah. And what the underpinning narrative over here is that he's likely got a sore throat, which has caused him to have a febrile convulsion, and the seizure has resulted in a proteinuria. Okay. And essentially, with transient proteinuриas, once the trigger of the proteinuria is removed, things tend to improve. So another more subacute example of transient proteinuria is pregnancy. Yeah, so a lot of women do get proteinuria when they're pregnant. However, once the baby is delivered, proteinuria tends to resolve itself. Okay. Looking at the other options, so the reason he's got positive ketones here is that he's been off his food for a little while. Okay, so as I said, when children get unwell, they don't need to eat as much, and then they do get a positive ketonuria. Okay, but glucose is negative, and this doesn't really point towards diabetes mellitus. His observations are normal, so we wouldn't tend to suspect hypertension here, and hypertension tends to be quite rare in children anyway. Yeah. Minimal change disease, the proteinuria is not that pronounced. Okay, well, 2+ is, but essentially you'd want typically 3+ proteinuria for minimal change disease. Yeah. And FSGS, once again, there's nothing, given the history of the seizure and the upper respiratory tract infection, this is not what we're thinking. Okay. So, here are the key things to know about isolated proteinuria in children, okay? The key thing you must all know is nephrotic syndrome. So we had a question on that earlier, but you need to know the triad. Yeah, the classical definition is 3.5 grams of proteinuria per day, okay? We now don't need to do 24-hour urine collections. We can use urine dips to get approximates and do albumin and protein creatinine ratios. We can also, and then what they also need is edema and azotemia. And what that essentially means is raised urea and creatinine. Okay? So that is the definition of nephrotic syndrome. Right? So that is the main cause of significant proteinuria in children. Now, transient proteinuria is the most common reason for children to have protein positive in their urine. And that is basically triggered by acute events. So seizures and infections are the main ones. So seizures in this case. But typically heavy exercise can do it as well. That you will tend to see that more in adults. And then, as just mentioned earlier, pregnancy is another example. And it's transient, it's benign. And once these triggers go away, the proteinuria recedes. We do not need to do anything about it. Okay. Now, the most common cause of persistent isolated proteinuria is something called orthostatic proteinuria. And we don't actually quite know the mechanisms that underpin this, to be honest, but it typically peaks in adolescence, and this proteinuria tends to persist thereafter. And what they essentially need is yearly follow-up, just with the urine dip and checking their blood pressure and just making sure everything's okay. But the prognosis is good, and it is generally benign. Okay. So this is quite small print, but it's worth knowing about because it is the most common cause. So I think people often tend to look at nephrotic syndrome and get quite distracted with nephrotic syndrome for proteinuria, especially in children. But the epidemiology tends to point towards these two, transient proteinuria and orthostatic proteinuria. And it's worth you knowing about this because essentially you will need to know how to interpret that urine dip after you've tried to find a focal source for infection in a febrile convulsion. And you might see positive protein, and you can, having an understanding that transient proteinuria exists is very helpful. Okay? And essentially, if the proteinuria persists, you then want to try and quantify the protein. Okay? And then you'll discuss with pediatrics and pediatric nephrology, depending on your local service setup. This is just a quick overview of the 3 key things I'd want you to know. Yeah, and I'm sure all of you know lots about nephrotic syndrome, but just for your practice, these 2 are important as well. Now, question 9. So this is a further stretch and challenge question that some of you may know. So we'll give a minute for this question.
10 seconds.
Okay. So around 45% have gone for option A, around 30% have gone for option C, and then 20% have gone for option D. Okay, this is a tricky question. This is essentially, unfortunately, one of those what's the syndrome questions, and you either can spot the constellation of symptoms or not. And we tend to typically avoid questions like this, but this is a good way of seeing whether you understand certain disease processes. So the correct answer here, okay, and provides some stimulus for your lungs to develop. Okay, but if that's not there, your lungs won't develop as well, so you get pulmonary hypoplasia. The amniotic fluid also results in a cushion being formed between the fetus and the external environment. Yeah, so if that cushion isn't there, whenever something presses against the fetus, or if, say, the mother lies down, or for whatever reason, it can result in skin changes and abnormal facies as a result, because things just appear malformed. And then they also get extremity malformations, sort of along the same reasons as well. Okay. And the way amniotic fluid is produced is essentially via the baby. So it is what the baby passes out through their, what would be their urine, yeah? So through their renal tract. So the reason there could be oligohydramnios or no amniotic fluid is a whole host of reasons, okay? But essentially, if there's renal agenesis, and that technically is what we would call Potter syndrome, but if there is anything stopping the urine production, so if, let's say there's an obstruction anywhere along the tract, yeah, that can result in oligohydramnios or complete absence of amniotic fluid. And in that case, we call it Potter sequence, because the disease process, the pathophysiological sequence is the same and it results in the same output. But Potter syndrome typically tends to refer to renal agenesis, so no kidneys whatsoever. Okay. So this is quite a difficult question, but some of you may have come across this in your reading, and it probably would be a stretch and challenge question to discriminate against basically those who have extensive knowledge in pediatrics. But I'll put up a mnemonic over here, which might help you memorize it. Okay. But if nothing else, try and think about the pathophysiology that underpins this. And that often tends to make it a lot easier. And I couldn't put any pictures on due to copyright, but it's also worth you going onto Google and taking a look at some images, looking at a pediatric atlas of pathology and seeing what a baby with Potter sequence looks like. Okay. But as said, this is getting more small print. And what I'd essentially want you guys to focus on as undergraduates in pediatrics is knowing about urine monitoring and collection really well, knowing about UTI, Haemolytic Uraemic Syndrome, and idiopathic nephrotic syndrome very well. Yeah, those are the key areas you should be focusing on. And then everything else is a bonus if you have got the capacity and the time to absorb more pediatrics. Okay. But I thought I'd highlight the range of pathology just to keep it interesting, but also, as said, the aspects of isolated proteinuria tend to be quite common, but often tend to be missed by undergraduates sometimes. Yeah, so I hope that's been helpful. And yeah, I'll now take questions from the group. Thank you very much.